In this screencast, we will be discussing the etiologies and patterns of small bowel inflammation. At the end of this screencast, I hope you will be able to identify and describe the different manifestations of inflammation and provide a differential diagnosis for the etiology of inflammation of the small bowel. So let's start talking about small bowel inflammation in general. Small bowel inflammation is typically characterized by a pattern of mural stratification. The mural stratification that results in wall thickening of the bowel often has some associated stranding or edema within the mesentery and may also see adenopathy within the distribution of the inflammation. Etiologies are listed here, so inflammatory bowel disease like Crohn's disease, infection, graft versus host disease, vasculitis, and drug reactions are going to be the most common etiologies and should be the foundation of your differential when you see mural stratification and mesenteric edema. Crohn's disease is going to be the most common form of small bowel inflammation that you're going to encounter in your practice. When we talk about mural stratification is a form of wall thickening of the small bowel where the submucosa of the small bowel becomes edematous or inflamed. This causes thickening of the wall with low attenuation submucosa. The inner wall of the bowel, or the mucosa, often appears hyperemic to the submucosa, and the outer wall may also appear hyperemic. When we talk about Crohn's disease is characterized by skip lesions or segmental transmural inflammation. We can break Crohn's disease down into three basic components. Active inflammation, where you have an inflammatory process that's resulting in wall thickening and edema. You have arterial hyperenhancement of the inner wall, what used to be referred to as mucosal hyperemia. However, we now know that often in Crohn's disease that mucosa has actually been eroded or ulcerated and the mucosa itself may not be present. You will often have stranding associated with active inflammation. So when you see mural stratification, luminal narrowing, inner wall hyperenhancement, mesenteric stranding, those are the cornerstones of active inflammation. And that's what we need to be calling the findings of Crohn's disease when they come together like that. Active inflammation, which is often treated medically as opposed to surgically. We then have stricturing disease. Stricturing disease tends to be more of a chronic form of Crohn's disease in which there's luminal narrowing and fibrosis that's resulting in upstream dilation or even obstruction of the bowel. So in these cases, you can have superimposed active inflammation, but in chronic stricturing disease, even after you treat medically to reduce the Crohn's flare, you still have obstructive symptoms, and stricturing disease tends to be managed surgically. Penetrating disease is the most severe form of Crohn's disease. In penetrating disease, we tend to see abscess formation, or what is now often referred to as an inflammatory mass, and we can also see the formation of fistula. Fistula can be between loops of small bowel, between small bowel and colon, between colon and the vagina or the bladder, or between small bowel and the vagina or the bladder. Penetrating disease is distinct from active inflammation or stricturing disease in that it often is treated medically in the hyperacute phase, and once the active inflammation is decreased, a surgical intervention is often necessary, although we are moving more to interventional radiology treatments such as percutaneous drainage of abscesses or inflammatory masses. Infectious enteritis is another common form of small bowel inflammation. It is often characterized by mural stratification similar to Crohn's disease, but typically the mural stratification and affected segments of small bowel are continuous and long segment, as opposed to multiple short discontinuous segments as we see within Crohn's disease. You can have both viral and bacterial causes of enteritis. Some classic etiologies for bacterial infection are going to be Yersinia or tuberculosis, and these tend to selectively involve the terminal ileum and the cecum. Viral enteritis tends to be more diffuse or long segment, and it's often mild. Many times, viral enteritis will have no apparent radiographic manifestation. Typhlitis is another type of infectious enteritis that is seen in immunocompromised patients, often patients who have neutropenia. It is felt that in patients with severe neutropenia, there is transmural migration of small bowel or colonic flora that results in inflammation of the bowel wall. Here on our right-hand side, we see two different examples of infectious enteritis. The top example is related to CMV virus, and it is affecting the ileum. We can see mural stratification where there's inner wall hyperenhancement and submucosal edema. We see associated stranding in the mesentery, and we also see increased vascularity of the mesentery, often referred to as mesenteric hyperemia. In the lower example, we see long segment severe wall thickening. Again, this is in a mural stratification pattern where we see that low attenuation submucosal edema and the inner wall mucosal hyperemia or inner wall enhancement. We can see some free fluid in this example and some associated mesenteric edema. This was a person who had eaten shellfish in Charleston and came down with Edwardiella tarda ileitis, previously known as Vibrio cholera. Graft versus host disease is a form of small bowel inflammation that is commonly seen in tertiary and quaternary care centers that are treating patients with leukemia, amyloidosis, lymphoma, multiple myeloma, or any other condition that may require a bone marrow transplant. In graft versus host disease, the transplanted hematopoietic cells generate white blood cells that go and attack the recipient's tissue. The tissues that are most commonly affected are the bowel, the skin, and the liver. The first manifestation of graft versus host disease clinically is often diarrhea or a rash. Hyperbilirubinemia can often be seen as well on laboratory tests. There are both acute and chronic forms of graft versus host disease. You often treat graft versus host disease with immunosuppression. And in graft versus host disease, similar to infectious enteritis, you tend to see a long segment of affected bowel. The wall thickening related to graft versus host disease often results in a mural stratification with a mucosal hyperenhancement. You can sometimes see some bowel dilation, and there is very commonly mesenteric edema, a comb sign or mesenteric hyperemia, and ascites. So similar to infectious enteritis, graft versus host disease is long segment mural stratification of the small bowel. And the biggest way you can differentiate these two is infectious enteritis tends to occur more commonly in neutropenic patients or immunocompromised patients who have not yet received a bone marrow transplant, where graft versus host disease is isolated to patients who have undergone bone marrow transplantation. Here we can see on the right-hand side of our screen an example of graft versus host disease where we have almost all of the small bowel within our field of view affected. There's wall thickening, there's submucosal edema, inner wall hyperenhancement, mesenteric stranding, and mucosal hyperemia. Small vessel vasculitis is sort of a wastebasket term for a large number of different autoimmune conditions. The most common ones are going to be C. ANCA, or previously known as Wegener's granulomatosis, lupus, and rheumatoid arthritis. There is a wide variety of presentations of vasculitis, but whenever you do see long segment wall thickening and you don't have some other etiology to explain the small bowel wall thickening, vasculitis is going to be within your differential. While vasculitis can present with these similar findings of long segment mural stratification and mucosal hyperemia, mesenteric edema. It doesn't necessarily have to present that way. And that's due to the heterogeneity of all the different vasculitides that you can encounter. But remember in the back of your mind when you see some abnormal bowel wall that vasculitis is one of those things that can mimic a lot of other pathologies and should often be within your differential. A commonly forgotten etiology for small bowel inflammation is drug-related inflammation. There's multiple different types of drug-related inflammation. One that often comes to people's mind is related to nonsteroidal anti-inflammatories. Nonsteroidal anti-inflammatories tend to affect the stomach and duodenum as opposed to the jejunum or the ileum, and it can result in duodenal webs and strictures, peptic ulcer disease, and you may see mural stratification within the duodenum. And if you see something impacting the duodenum, the duodenum is less frequently involved with these infectious enteritises or these etiologies related to being immunocompromised. And so start to think of NSAIDs as a common etiology when you see edema within the duodenum. ACE inhibitors can also impact the small bowel. The ACE inhibitors cause angioedema within the small bowel, and that's going to manifest as long segment mural stratification. It's often presenting with chronic or recurrent nausea or abdominal pain, and it just doesn't often come to the mind of the radiologist or the primary care physician that the patient's on an ACE inhibitor such as lisinopril, and this can be a misdiagnosed or underdiagnosed etiology of chronic small bowel inflammation. Chemotherapy can result in an enteritis, and in the case of chemotherapy, the enteritis results from the chemotherapy disrupting cell division of the mucosa. So the mucosa is one of the more rapidly dividing cell populations in our body, and because chemotherapy is trying to target cell division, the mucosa can be impacted by the chemotherapy. That mucosa dying can allow transmural migration of small bowel flora and cause inflammation and even bacteremia. One of the most common chemotherapy agents to result in enteritis is irinotecan, and irinotecan is a common agent to treat colon cancer. Radiation enteritis is another commonly encountered etiology for small bowel inflammation. The loops of bowel that are affected by radiation therapy tend to be those loops of bowel which fall within the radiated field. So if a person has cervical cancer and there are low-lying loops of ileum, or if the person has retroperitoneal adenopathy, the loops of bowel in the central abdomen will often be impacted by the radiation. Similar to chemotherapy, the radiation often disproportionately impacts rapidly dividing cell populations, which the mucosa of the bowel is. So you get inflammation or cell death within the mucosa, and that results in acute inflammation and edema that may manifest as mural stratification in the period of time while the patient's receiving radiation or soon after receiving radiation. And then after the radiation therapy has been terminated, over time, that active inflammation can result in fibrosis and scarring of the bowel, and it can also result in a small vessel vasculitis that causes ischemia. So the chronic manifestations of radiation enteritis tend to be stricture or can even be fistulization with adjacent organs, such as fistulization to the bladder or the vagina or the colon. In summary, small bowel inflammation tends to be characterized by uniform circumferential wall thickening. This is nonspecific, but most commonly it's inflammation or edema that causes that uniform wall thickening. When you do have IV contrast, you often see a mural stratification pattern with submucosal edema and interwall hyperenhancement. Inflammation tends to also cause edema within the mesentery, so look for mesenteric stranding associated with mural stratification. If you see short segment or multiple segments, and particularly a short segment of terminal ileum with other skip lesions proximal, think about Crohn disease. If you see something isolated to the terminal ileum, start to think infectious etiologies such as tuberculosis or Yersinia or Crohn disease. If you see very long segment or diffuse involvement of the small bowel, you want to start thinking about viral infections, less commonly bacterial infections, ischemia, angioedema related to ACE inhibitors, or the various vasculitides.
Hi again, this is Shivaraman from Johns Hopkins University. So why don't we conclude our survey of small bowel inflammation by talking about inflammatory bowel disease, which when you're talking about the small bowel, you're really discussing Crohn's disease. Now, Crohn's disease is a transmural inflammatory bowel disease that affects a large number of Americans and Europeans every year, somewhere in the order of 1.5 million. Unfortunately, clinical and laboratory markers are relatively nonspecific, and this is a diagnosis that's difficult to make short of doing either a biopsy or using a CT scan. And it is a diagnosis that's important. New drugs are increasingly efficacious, TNF-alpha inhibitors, steroids, salicylic acids. So this is a diagnosis that you want to be able to make accurately based on imaging. Now, CT enterography is actually a great test for making this diagnosis. It is at least as good as small bowel capsule endoscopy in making the diagnosis. And unlike a capsule, which is difficult or impossible to use in patients with strictures, CT enterography really has no contraindications. And I would argue that any patient with suspected Crohn's disease, before they go on to get an invasive test like a capsule, should get a CT enterography first to make sure that they don't have major complications that might preclude them getting the capsule. Now, Crohn's disease can involve any part of the GI tract extending from the mouth to the anus. In the earliest phases of involvement, you're just going to see subtle hyperemia, and that's going to be most prominent on the arterial phase images, and you may not see bowel wall thickening at all. As it goes on and as the inflammation gets more and more severe, you start to see frank bowel wall thickening with mucosal hyperemia. You see it not only in the arterial phase images, but on the venous phase images as well. And you start to see mural stratification with hypodense submucosal edema and serosal hyperemia. Now, classically, Crohn's disease is most likely to involve the distal small bowel. Notice in this example, there is dramatic thickening of maybe about a 15 centimeter segment of distal small bowel going to the terminal ileum with dramatic mucosal hyperemia and significant engorgement of the vasa recta. That's a classic distribution of Crohn's. Now, as I mentioned, one of the reasons why I think dual phase technique is so helpful when you're trying to image a patient with Crohn's disease is that in the earliest phases of the disease, you may not see bowel wall thickening, and you may just see very subtle you may see very subtle engorgement of the vasa recta and mesenteric hyperemia that is only going to be appreciable on the arterial phase. And here's an example of that. This is a patient where the venous phase images look totally normal, and if you looked at the bowel on the arterial phase, it looked pretty normal as well. But using MIP reconstructions, 3D vascular reconstruction techniques, you can see that there is very subtle engorgement of the vasa recta going to the right lower quadrant. Mesenteric hyperemia can precede signs of overt bowel wall thickening, and so that's one of the reasons why I really recommend utilizing dual phase technique, and more than that, utilizing 3D reconstructions as part of your daily routine practice. Now, just as you get relatively consistent findings in the acute setting, there are also a series of relatively consistent findings that you can expect in the chronic setting, and these are patients who have had multiple repetitive bouts of bowel inflammation. Over time, as a result of that inflammation, you're going to see deposition of fat within the wall of the bowel, so-called intramural fat deposition. The bowel that's involved will lose its normal fold pattern. You may see ahaustral bowel in the colon in particular, loss of those normal folds. You can see strictures, and you have to be on the lookout for evidence of frank obstruction, because strictures, after all, will preclude the patient getting a capsule endoscopy. Now, you may not always see it on a CT scan, but sometimes you'll see pseudosaculations along the mesenteric border of the bowel, probably secondary to asymmetric fibrosis. So here's an example of a patient who has creeping fat and intramural fat deposition. Notice how there's diffuse submucosal or intramural fat throughout the colon and rectum, suggesting that this patient has had repetitive, multiple bouts of colonic inflammation. Now, I will warn you, While this can be seen in the setting of chronic repetitive inflammation, it can also be associated with patients who have diabetes or severe obesity. So it's not always going to be, every time you see this, you can't necessarily jump to the diagnosis of Crohn's or inflammatory bowel disease. Here's another example, this time in a patient who has a chronic stricture as a result of prior Crohn's disease. Now notice the lack of significant hyperenhancement or hyperemia at this site, suggesting that it's likely chronic. But that being said, I will admit that it can be very difficult in many cases to be certain whether you're dealing with an acute or a chronic stricture. Now, once you've made the diagnosis of acute or chronic bowel inflammation, the next step is to look for any one of a number of common complications that may result from the patient's inflammatory bowel disease. Crohn's disease is very often associated with fistulas, and about a third of all patients will develop a fistula within a decade of symptom onset. And the most common location for developing perianal fistulas is going to be the perianal region. Now, the most sensitive signs of a fistula on a CT scan, of course, are going to be directly seeing a fistulous tract between one bowel loop and another. And if you see that, it's not going to be difficult. And if you're really lucky, you're going to see contrast going from one loop to another. But I will point out that you have to be able to make the diagnosis of a fistula based on secondary findings as well. You may not necessarily see the fistula's tract, but in many cases, if I see multiple tethered, radiating loops coming towards a central point with ectopic gas, stranding, density, and spiculation of those bowel loops, then I'm going to be able to make the diagnosis of complex fistulizing Crohn's disease, even if I don't necessarily see the fistulous tract itself. Now, it goes without saying, if you're worried about a fistula, it is helpful to give positive oral contrast. Now, let me also note that perianal fistulas are the most common location, and while you may be able to surmise the presence of a perianal fistula based on stranding, edema, or fluid in the perianal region, MRI is actually a better test for really delineating the presence of a perianal fistula. Now, as I mentioned, the best way to make this diagnosis, or the most specific way, is if you see a discrete fistulous tract. And oftentimes, these tracts can be best appreciated on volume rendered or MIP images. Here are a couple examples, right? Not exactly diagnostic dilemmas. Thickened, inflamed bowel loops. There's clearly a fistulous tract in both cases, connecting different small and large bowel loops. And so these are enteroenteric and enterocolonic fistulas. But what you really need to be able to do is make the diagnosis when you don't see a fistulous tract, because complex fistulizing Crohn's disease without a discrete tract on a CT scan is far more common in clinical practice. So in these examples, notice how all of these bowel loops are inflamed, they're tethered, they're radiating towards the point. You see ectopic gas right at the center, and there's lots of edema, stranding, and inflammation interspersed amongst those bowel loops. When I see those bowel loops spiculated towards a central point of ectopic gas, as in this case, regardless of whether I see the actual fistulous tract or not, I'm going to make the diagnosis of complex fistulizing Crohn's disease, and in this case, multiple discrete enteroenteric fistulas. Now, you don't necessarily have to have a fistula just with the small bowel or the large bowel. You can have fistulas with other organs or structures as well, and I'd say one of the most common of those is going to be an entrovesicular fistula. And in this case, you see markedly thickened, markedly hyperemic, and inflamed small bowel. It's directly adjacent to the bladder. And notice that at the site of contact between the bladder and the small bowel, the bladder is markedly thickened, dramatically hyperemic, and there's a loss of the intervening fat plane. Now, there are some people who won't make the diagnosis of an entrovesicular fistula unless they see a discrete tract. So they want to see a direct air or fluid-filled tract going between the bladder and the adjacent bowel. But in my experience, I'll tell you, that is quite rare. And if you are that stringent about making the diagnosis, you're going to miss quite a few cases. As far as I'm concerned, if I see a patient with thickened, inflamed bowel, there's a loss of fat plane between the bowel and the adjacent bladder, and the bladder looks focally thickened and focally inflamed at the site of contact, even if I don't see ectopic gas within the bladder, I'm at least going to raise the possibility that there may be an entrovesicular fistula. So, in conclusion, hopefully over the course of this 4-part lecture, I've given you a sense for how critical it is to have proper CT technique in order to appropriately evaluate small bowel wall enhancement and small bowel wall thickening. Many of the diagnoses that I've talked about during the course of this lecture would have been very difficult with inappropriate technique. If you're going to do these studies and you're trying to evaluate the small bowel, you really have to use volumen, not a positive oral contrast agent. And I would recommend going to ctsus.com and taking a look at some of the enterography protocols that Dr. Fisherman's put together. Second, As I've tried to show you, there is a substantial overlap in the imaging appearances of many of the disorders that I've talked about. So, in point of fact, you may not be able to make a specific diagnosis purely based on the imaging features alone, and you have to take into account the patient's clinical history in order to provide a smaller differential diagnosis or even a specific diagnosis. At some point, there's nothing wrong with providing a useful short differential diagnosis rather than trying to guess and provide a more specific one. Third, always be thinking about bowel ischemia. I've always been worried about this diagnosis. I'm always scared of missing this diagnosis because this is a diagnosis, if missed, that can really result in a patient's death. So anytime you're confronted with abnormal small bowel, make sure you're at least thinking about the possibility of bowel ischemia and make sure that you carefully evaluate both the SMA and the SMV in every single patient who presents with acute abdominal pain. So that's it. So until next time, this is Shivaraman from Johns Hopkins University. Thanks a lot.
Does. So I think we'll be in good shape. So quickly, I'm just going to go through a little bit of the scope. A lot of you guys know this already. The prevalence, they know the highest is in Europe and North America. Europe about 505 per 100,000 in Norway, and Crohn's is about 322 per 100,000 in Germany. And in North America, it's a little bit less than the European. In New York, ours seems to be higher. So we're probably closer to the European prevalence. And so about 1.6 million have it, and it's been rising in Africa, Asia, and South America. Unclear, a lot of people think it's because it's a viral cause, and it causes a lot of physician visits and hospitalizations, and the biologics are really expensive. You know, a lot of the clinicians we work with go through why they need to pick this up early, and it's because of the quality of life going towards the delayed treatment and worse outcomes. So really, they always do a history and physical, and they get their labs, but where do we come in? And where we come in is kind of when they're not really wanting to do capsule endoscopy. There's a lot of problems because it gets so many images, it can still miss things. Sometimes it gets stuck behind a stricture, and then you have to actually have the problem of getting the capsule out. And really, CT and MR are pretty well tolerated. So the goals are you always want to induce clinical remission, avoid short and long-term toxicity, improve quality of life, and you really want people to not be on steroids. And the real goal that everyone talks about is mucosal healing. And so if you work with the surgeons, they want us to see the mucosal healing. And then you want to prevent the complications and reduce cancer risk. So what's thought to happen is that early on in the disease, you kind of have this waxing and waning kind of progression, but overall it kind of goes up. So you have preclinical, and then with the clinical, you start forming the strictures, the abscesses, then you go to surgery, and then everyone sees you get the strictures at the ileocolic and anastomoses, and then you start chopping away at the gut, and then you're at risk of short bowel syndrome. So really, and what are the risk factors are when they present early, when you have perianal involvement with those severe deep ulcerations, multiple areas, if they're smokers, and then of course, as soon as surgery gets involved, it's a bad kind of, you start having that cascading event of surgery leading to more surgery. And the early steroid is a bad prognostic. Ulcerative colitis, again, early age, early steroid treatment, all of this current research is on how steroid treatment is bad and how it kind of portends an overall worse prognosis. So this is leading to a shift in how people are thinking, which was old used to base on symptoms.
So I have a question.
Yes.
On the last slide, steroid use is bad. Is it just because the disease is severe and they require steroids, or is it the actual steroid use?
To it. Yeah,
oh.
No, it's bad. It's associated with it, but steroids themselves are bad. I'm going to I think it's on a later slide, but it's a good question. So let me go forward. But yes, I will address that shortly after this because I'm going to get into the meds. So now everybody is trying to talk about basing on C-reactive protein reduction. You want to see mucosal healing for those people. I don't know if anyone's from Sinai on the call, but that's what they all do. Their aim is for mucosal healing. And we can see that. and then you're looking for improvement radiographically. So this is what the steroid issue is. So it used to be it was step-up therapy. So you would start with a steroid when they presented at low dose, and then you would go to systemic. Then you would go up to the TNF, anti-TNF alphas, and then finally you would do investigative agents. And so it was essentially, you would step it up according to severity. The problem with that, so the advantage is you wouldn't give them the hard-hitting anti-TNF until they were really progressed. And so you would reserve it for refractory disease. And it was cost-bearing. But the problem was you had to earn the more effective treatments because those work better. And you would use these steroids, which have all kinds of side effects like obesity, sluggishness, hypertension, et cetera. And it would delay your optimal therapy. And so the disease course was not modified. So this is kind of leading to a thought change, which is instead of the corticosteroids and then you earn up to the TNF, now you're starting with immunomodulators and TNF antagonists early and moving down. And so it's now a bottom-down approach is kind of the way people are starting to talk about this. So while the current approach was you assess their prognosis and then you would say, oh, maybe we'll start earlier with a biologic. The emerging approach is that you're going to give them harder drugs earlier, tailored to their particular side effect profile. And these are all of the current active medications that people are using for this disease. And they're using it, instead of just the corticosteroids, they're moving on to the immunomodulators and TNF alphas. And so this is what is wrong with steroids. Hypertension, the diabetes risk increases. You get increased risk of infection, osteoporosis, myopathy, and cataracts, as well as rarely you get the psychosis. So generally, most people are starting to move away from the long-term steroid treatment because of all of this and because of improved therapy. So knowing this, how can we help and how can we start giving more information? And so what it's thought to be is that it complements ileocolonoscopy. So you can visualize the small bowel inflammation in about 50% of Crohn's, even when they're endoscopically normal, usually because they can only get to the TI, right? So they can't see more proximal disease. It's great for diagnosis, determining distribution and complications, perhaps, and this is kind of where the current thought is can we monitor disease progression? And then finally, we know we overstage patients and up to 21% when they're clinically having remission. So this is what, is annoying when you're doing these follow-ups and it still looks horrible. But you're kind of like wondering how long there's memory of the bowel to just look the same. And then we know that MR stages disease only properly in about 62%. But it's excellent for moderate to severe. So we're really good at picking up abscesses and huge fistulas and, things like that. So what about CTE versus MRE? People get into very big fights here about this. Generally, our clinicians prefer CTE because they can read it easier. It's not as many sequences, but the radiation is the big issue that people do. The MRE is great. It depends on the quality of your magnet, obviously, but so you need to have highly trained technologists. So, here you can see, So this is same patient, CT versus MR, kind of similar. Those of you that are purists would say you like this CT better because of the improved revolution. You've got some motion there, but you can see the layered enhancement of this segment of bowel nicely. You can see here this little fistula coming out. So they're equivalent. Penetrating complications are equivalent. For stricturing, MRE is thought to be a little bit better because you can do those cine images, but really they're both pretty good. And this is the protocol that we do here. Sometimes it's pretty hard to have them actually drink the full 1350, and we do it really thin slices. So you can see a really beautiful example here. Basically, this is our MR enterography. We've been cutting it now during COVID. RECT has been on this big push to get all of our scans even quicker than before. So we've had all these working groups, and I think we had to cut out like 10 minutes from every protocol. So this is not the up-to-date version, which is going to be released soon, and I'm sure we're all going to complain about it when it comes out. But this is what we do. Now we've moved to Brisa, and they are supposed to drink it, and we try and have them complete it for it. Again, almost no one completes drinking it. So a lot of this is based on this wonderful article from Bruning, where they went through and had this kind of great depiction of everything, describing it. So this was a pictorial from it showing like, how do you describe things? So you would say, oh, if it's normal, you would describe it as normal. And then you go on the spectrum with, do you have a penetrating complication showing the bowel lumen with this sinus tract coming out and communicating with another bowel loop? This is non-specific inflammation. And then they go through kind of depictors of narrowing without dilatation or stricture where you have fixed dilatation. And this was all their recommended reporting findings. I'm not going to get too much into it. I'm happy to send this to anyone who wants a version. But essentially what you have is active inflammation. So active inflammation, mural stratification, that's where you see this layered enhancement where it's hyper intense along the mucosa. Then you have that hypo-intense area in the submucosa, and then hyper intense again in the serosa. That target sign is a well-established indicator of active inflammation. Here you can see it. This is a little blurry, so it's not as pretty, but you can clearly see the smooth mural enhancement here. Active inflammation of the bowel wall. Can you see high signal intensity edema within it? That's clearly going to be active inflammation. On CT, again, you get that layered enhancement, bright, dark, bright. And so that goes along with active disease. We know wall thickening is really nonspecific, and this was what was proposed as the mild to moderate to severe. How are we, and this is really what our IBD specialists want us to comment on, is this mucosal ulceration. So what you see is as you're enhancing, you see this shagginess and these divots. So this is clearly mucosal ulceration. And if you can pick this up and describe this to your inflammatory bowel disease doctors, they will love it, because you will say, oh, this is clearly mucosal disease with irregularity. Because when they're going to go do an endoscopy, they'll say, okay, I want to know when this improves, and that will be a non-invasive marker of improvement of these drugs that we're using. And so this is really reliable for it if you can pick this up. So here's a patient, and here you can see this is like disease here. And as we come down, you can see these are clearly ulcerations in this loop of bowel. And so that actually shows them they've got a lot of work to do in improving that. What about restricted diffusion? It's sensitive for active inflammation, but unfortunately the bowel has a long memory. And so sometimes you will see that there's some mildly high signal on these high B values. And sometimes this will persist even after the disease has gotten better, which is why we're not so great for mild disease. So it's not really specific. So you need to have other markers of active inflammation. And then again, this is active inflammation. It's bright on high B value, and then it's somewhat low on ADC here. And then on haste, you can see it looks, okay, this bowel lumen is thickened. It looks like there's some submucosal edema. So clearly you're going to call this active inflammation. This is also active Crohn's. And this one actually, you can see the mucosa looks pretty nicely preserved. We don't have that many of those ulcerations, so it would be nice to depict. And again, the diffusion shows bright, low ADC, and then this person actually had some perianal disease. So, and then you're supposed to, what are you supposed to say? You're supposed to say severity, give an estimate of the severity, then you say the location and length. So actually we often will mark, X amount of distance from the TI. This is the length of the segment of involvement, skip lesion, anti-mesenteric sacculation, another skip lesion involving the distal blah. Is there, and then this one, is it actually strictured? I'm going to get into that because we're terrible at actually predicting that. And so one of the major complications is these strictures. And so here you would say, okay, that looks like it's going to be a stricture. You've got proximal bowel dilatation. And I'm going to say, but a lot of the times it's a mixture of both active inflammation and a fibrotic component. So how good is luminal narrowing? You definitely need to have it, but it's not sufficient. You would like to have upstream dilatation for you to suggest that this is actually a fibrostenotic stricture, more fibrotic than just inflammatory. And then some people have said, what about progressive delayed enhancement? So here you've got a target appearance, and then you get kind of that solid enhancement pattern. This is terrible. I've never seen that this works. I used to get in an argument with people about this all the time. Some of you will probably argue with me about it, but I've been burned so many times with this, because this is what it looks like. It's target and then it fills in. And so they used to say, okay, this actually suggested, some people would say that this was fibrotic, but then this paper suggested that this was actually active inflammation because it was stratified early. So some people say for it to be fibrotic, it has to be solid enhancement the whole time. I don't know if that actually even works. Stricturing disease, you report the length of the narrowed segment, and then you give the degree of upstream dilatation and the length. And again, this progressive delayed enhancement, I don't know how accurate that is. I'm going to show you a couple where we've messed up. And here, clearly, this is going to be an abscess.
Sorry, I have a question.
Yes?
So do you do multiphasic on your enterographies?
Yeah, we do. We do graft imaging, so it's very, very quickly done. On our MR, we do. On the CT, we do not.
Mm.
So you're right. Like that's, I mean, we do it in early phase for the CT. Some places do multi-phases for the CT, but I think part of the problem with that is, again, radiation dose. So, but like I'm telling you, I'm not even sure how much it helps. So here, the fistulizing is clearly helpful. Here is the stellate pattern. You can look for gas. This is clearly going outside of it. Here again is an abscess. That's pretty easy to see. This one was an abscess, again, post-contrast diffusion, very, very restricted. And I'm getting almost done. So here is the abscess. The role of IV is on MR. You see this phlegmonous-like mass. No one's supposed to use the term phlegmon anymore, but you've got an inflammatory mass here. But post-contrast, you can see that it has pockets of fluid. I don't know if it's actually drainable, big enough for someone in IR to actually get into it, or even if that would be wise. But essentially, you can diagnose it better as an actual abscess there. And so what do? We do the presence, absence, location, involved structures, and perianal disease. Again, here you can see several sinus tracts here, and you can see the blind ending sinus tract going into the mesenteric fat here. So again, how do you tell the difference? I don't know that anyone has reliably been able to tell the difference, and part of it is because it's on a spectrum. So you can suggest if you see upstream dilatation or if it's fixed over multiple sequences, if you're doing MR and you have cine images, and it usually is associated with fistulous disease, that suggests it's more severe. And then finally, if it is the fibrostenotic, the reason this is so important is that's when they go on to the surgical therapy, which you don't want to do if they're inflammatory and you can control it with the better drugs. So that's the problem. So here, is this fibrostenotic or inflammatory? We've got this fixed stricture here. It looks fixed on every sequence. Here it's very tight, short segment, you've got fatty proliferation, very distended proximally. Looks pretty solid enhancement, solid.
I say it's coexisting.
Well, yes, a lot of them are often, these are actually fibrostenotic. So this went on to fibrostenotic.
What about the DWI?
I didn't give you DWI on this one. Sorry.
Nicole,
I don't know.
One thing about fibrostenotic versus inflammatory, they tend to be shorter, right? Like the inflammatory ones are longer with.
Sorry. Yes, I skipped past that. But you're right. That's another way to help you, that this was a really short segment. So that would help you suggest that this was fibrostenotic. So that was fibrous.
How can we confidently exclude active inflammation?
I mean, so you will have to use all of the grab bag of tools that I just whirlwind whipped through.
No, in that previous case.
Yeah, so here, for example, this was a stenotic lesion with chronic SBO, and usually they've been imaged and that stricture's there over several months. So they don't make this decision lightly, and it's not all on the shoulder of the radiologist, right? So you often will say, listen, I'm doing the best with what I can under the situations in which I've been put. And so this is my best guess. There's usually an inflammatory component, but at this point, this is a large high-grade SBO, or this has been present. The guy's not improving clinically. His inflammatory markers have been stabilized. It's probably fibrostenotic. So you just use the whole tool set. So this was also, again, short segment. This was fibrostenotic, and you could argue here, is that somewhat layered, right? So it's not perfect. And this was actually an inflammatory stricture. So this one went on to surgery, and it was inflammatory. So that's where it's kind of, and it was short segment and it had been there for a while. You could argue because it was layered enhancement that you would have said it was inflammatory. But you can see it was dilated. It was dilated in the bowel distally as well as proximally.
So in the
All
prior
right, so
case, it didn't have the layered
26,
enhancement.
2019.
Is that why we are calling it a fibrostenotic stricture instead of an inflammatory? Not the
Sorry, I
one
didn't
before that
hear.
one. Like yeah. So in that case, you're calling that a fibrostenotic stricture and not an inflammatory because it didn't have the layered enhancement?
I'm just telling you, you mean why would you be able to predict that?
Or how do you exclude active inflammation?
Nellie, I think that what she's saying and my experience is that most people have some combination of the two, but I would have even said that I thought this was more fibrostenotic because even though there is some enhancement there, it's pretty short segment, it's pretty T2 hypointense. There's a lot of prestenotic dilatation, which just means it's a stricture, but that the other features of it to me look more fibrotic. So most of them will have some combination of the two, but this one seems like a dominant fibrostenosing disease and would potentially go to surgery versus the inflammatory ones, which would, go for medical therapy.
Gotcha.
Yes. Well said. Thank you, Arti. So anyways, yes. So you'll notice a trend. All of these fibrostenotic tend to be short segment, but like I said, this was, now you could argue the narrowed portion of this was short segment, but the inflammatory was probably longer segment. So it's often tricky with these. And so again, here was another one, and this one, you can see it's a pretty long segment, but there is a lot of dilatation. And in this segment that's narrowed, you can see some sinus tracts coming here, and then you've got this mucosal irregularity. So this one didn't go to surgery, they just increased the TNF alpha, progressed on the drugs, and this started to improve just with that type of therapy. So that would help you to argue for inflammation. But again, it's hard, right? And you said, like you said, it's a kind of a spectrum. So here was one, and it was, is this peristalsing? Do you see this as peristalsing? Looks pretty fixed, right? So people have said, oh, if it's fixed, you suggest that it's fibrostenotic, but that is not always the case. You can have active inflammation that causes lack of opening. So that was acute inflammation with no peristalsis. That was actually a false positive example. Here's another one where this was, I don't think it's going to play. This is also acute inflammation. And you can see engorged vasa recta, and there was additional signs suggesting that this was just active inflammation. So we know that peristalsis alone is not super helpful in predicting it. So probably your best bet is like what Arti already said, is like it's a really short segment, really dilated before it. You've got solid enhancement, no layered enhancement, and it's fixed on multiple segments, and the inflammatory markers are not elevated. Finally, I'm just going to end with some extraintestinal findings. Here you can see you've got some strange enhancement, which looks like it's in the sacrum itself, and this was actually osteomyelitis complicating a fistula, which had actually extended to the bone in this patient. Here is a man who's kind of getting image. You can see this perianal fistula kind of tracking down intersphincteric and terminating at the left gluteal cleft. So that was that, but what about the bones? Do you see anything here? So we got called from one of our rheumatologists, livid, that this was missed. I don't know how well you guys see what's going on here, but it's very subtle. It's just this dark signal along the SI joints. And when you get the corresponding plain film, it was actually quite obvious sacroiliitis, and she wanted to know why we had not mentioned it, because it affected the drugs that she would give them. So it's just be forewarned. It can actually be really hard to pick up on it. This is just from the Bruning article, going through what they recommend that's put into the report. And then finally, quickly, colorectal cancer risk. There's been a number that have been missed in these patients who are getting followed up because everyone attributes it to just Crohn's or UC. And so you know that the cancer increases the risk. currently what's recommended is they haven't had actually optimal surveillance for IBD. So they said you should get colonoscopy every 8 to 10 years. And we all know that they lowered the age of general colonoscopy, but it's kind of unknown for IBD what to do. And so they say you should get surveillance every 1 to 3 years, but that's a big difference. And so here was a young guy here that we just did, and it was a perianal Crohn's, inability to pass the scope. And you can see he's got massive inflammation here. And then as we go down, this looks like he's got a fistula here, and then this also looks like a fistula in the intersphincteric space coming back. But we asked them, it looks like a fistula. It looks like a fistula with an abscess, and it's tracking along that levator. So this is a terrible story. Here it is. Look at this degree of fecal loading proximal to this stricture down here. Here it is again, this thing, which looks really awful, and it looks like an abscess or a perianal fistula. And this was actually a submucosal infiltrating signet ring mucinous adenocarcinoma mimicking a fistula. Why was this so terrible? It was terrible because they actually put a ceton in it, didn't get any pus, re-imaged the guy, no one thought to send it for cells, and kept waiting. This thing kept growing. And then finally, I mean, this poor guy died, but it's essentially an awful case. These things tend to be very aggressive. And the problem also is when they could look at the lumen is normal because these are submucosal tumors, kind of like those awful insidious submucosal gastric tumors that just are really hard to pick up. And so this is like a scary thing. So in summary, there is need for increased specificity in reporting, and you have to know the context, look for mucosal healing, length of involved segments, and of course, be aware that we do overcall mild disease. We're really best with moderate severe, and do be aware of these complications. Thank you.
That was awesome.
Great talk.
I have a couple of questions.
Okay.
Okay, so you said to look for mucosal healing. By that, do you mean like on one study you saw the ulcerations and you called it, and then maybe by the next study you're not seeing the ulcers anymore?
Right, correct. And so there's some data out there saying that we're getting better at that. So like kind of here, for example, you would probably say this part looks pretty smooth. This part is not distended. You wouldn't call that healed. And that part looks irregular. But the thought is that as we get, we go up and like this is clearly horrible mucosal disease. But if you can suggest over time, well, and this is also ratty mucosal disease. If you can suggest, like if you can see this looks like if that were that same patient, you would say that looks like that's been healed. That's kind of like where the current future of IBD imaging is can we correlate well mucosal healing with imaging? And that's what a lot of the IBD doctors would like us to be able to tell them, because that's what their target is now as they've improved their drugs so much. They don't want just symptom control. They actually want essentially cure. And for them, cure is mucosal healing.
Cool. And then why should we not use the word phlegmon? Although I guess I don't know even what the full definition is, but is there a reason we
Well, I mean, from the Atlanta criteria and the Bruning criteria, essentially surgeons love that word, but people who are in charge of creating lexicons hate it because it is very nonspecific. Although honestly, they want us to say inflammatory mass. I don't know why that's more specific than phlegmon. So okay. I don't know. It's just it's a pet peeve of a lot of people. Anyone who's on this call who has contributed to that, please feel free to jump in. But I do know from the Atlanta criteria for acute pancreatitis, we're supposed to stop using that word. But I know surgeons love that word.
Maybe because phlegmon is suggesting like on its way to abscess or some kind of infection, whereas inflammatory mass is like not suggesting infection at all.
That could be it. But yeah.
Cool. Thank you.
I have a question.
Oh yeah, go ahead.
The slide said that we overstage patients in 20%. So what do you do in those cases where you have like mild disease and you're not sure if there's response or it's just persistence?
I mean, we read it what we see. It's kind of like cholangitis. the imaging findings of, peribiliary enhancement persist like up to 6-7 months after the patient's completely asymptomatic. So I often will say, I'll talk to the referrer and I'll just be like, look, it looks like they're still actively cholangitic, but I see that their LFTs are completely normal. Therefore, this is an imaging finding that has failed you because I am seeing something that is like obviously just a long memory. And I'll just say the same thing for the disease on Crohn's. And usually your referrers will know that. Like they're just looking for lack of progression. As long as you read it as persistent inflammation, if they've just done a scope and seen mucosal healing, they'll just ignore it.
Awesome.
But yes, we're flawed. We just know that it is.
Nicole, that's fantastic. I mean, you took me to a new place. I'm going to start using the word ulceration maybe in these reports for the first time ever after this.
Oh, good.
I know. I'm excited about it too. I've never used it.
Okay.
Apparently, I've missed a bunch of
23.
Yeah.
First
Well,
I have to know what I'm talking about, but that's part two.
Now we're going to overcall that.
yes. Well, at least it's an attempt. It's an attempt to have more fun with these horrible cases. I should show you, I didn't put it in here. I should show you, we have this guy, Remzi. I think.
You will no longer hear beeps until someone else joins the conference.
Okay, بسم الله الرحمن الرحيم. اللهم لا سهل إلا ما جعلته سهلا وأنت تجعل الحزن إذا شئت سهلا ولا حول ولا قوة إلا بالله. CT enterography, MR enterography, and inflammatory bowel disease. I have presented this lecture in the half academic day for the radiology residents in the Western region on January 25th, 2016. No disclosures. As an introduction, there is not a few number of conditions involving the small bowel. Since the start of medicine, many efforts were conducted to diagnose these diseases. And there are different studies and modalities that have been developed. So in order to image the small bowel follow through, which is when the patient drinks oral contrast and we wait till it reaches the small bowel, then a series of X-ray images are obtained to visualize the progression of the positive oral contrast till it reaches the ileocecal valve and to demonstrate the mucosal outline of the small bowel. In small bowel enterocolitis, also known as small bowel enema, a nasoenteric tube is introduced under fluoroscopy and then the contrast is injected through that tube. However, this kind of studies is invasive and is not preferred by many patients. CT enterography is a modulation or a modification of conventional CT abdomen and pelvis, in which the small bowel is distended uniformly from the ligament of Trias down to the ileocecal valve. Enterocolitis, the same idea, as nasoenteric tube is introduced and the contrast is injected through that tube. Then there's MR enterography and MR enterocolitis. It's an MRI of the abdomen with distension of the small bowel. The gastroenterologists, they developed the capsule endoscopy, in which a camera is ingested by the patient and then hundreds to thousands of images are taken by that camera and sent to a receiver that is worn by the patient, and then these hundreds to thousands of images are analyzed by a gastroenterologist and in order to detect the diseases. The disadvantages of such conditions that the capsule cannot be taken in case of total or complete small bowel obstruction because it will stop there and it might lead to propagation of symptoms. Double balloon endoscopy is a newly introduced kind of endoscopy in which a small bowel is visualized. In ileocolonoscopy, it's a conventional lower GI endoscopy with an attempt to visualize the terminal ileum. It's really useful in case of ulcerative colitis with backwash ileitis. So CT enterography, that's our subject for today, plus the MR enterography. It was introduced in 1997. As I mentioned earlier, it's a modification to the conventional CT abdomen and pelvis with proper distension of the small bowel, and it was introduced mainly for Crohn's disease. And the difference between enterography and enterocolitis we have discussed earlier. So the indications mainly is Crohn's disease. Then they found other indications like occult GI bleeding, small bowel tumors, i.e. the neuroendocrine tumors, because the CT enterography requires multiple phases, and they found that it's useful in these hypervascular lesions. In mesenteric ischemia, it is found in borderline or non-conclusive cases because of the adequate distension of the small bowel loops. So let's say that a resident received a CT requisition requesting to rule out bowel ischemia. So he should do the routine CT mesenteric ischemia protocol. But if the study was not conclusive, he can suggest CT enterography to be done the next working day. Advantages: it's non-invasive, it's easy to perform, it's widely available based on the availability of the CT machines. As expected, the extraenteric findings can be detected and the whole bowel wall can be visualized. Now, this is what I guess might be an MCQ question. It has a good spatial and temporal resolution as compared to MR enterography, which has a good contrast resolution. So CT enterography has a better resolution in differentiating between minute objects. The disadvantages: radiation, the contraindication to, the complications of IV contrast, such as allergy, contrast-induced nephropathy, and most importantly, diarrhea. The reason of diarrhea is because of the large amount of oral contrast taken by the patient, plus the nature of this contrast, which keeps the water within the small bowel, leading to the watery diarrhea. So we will start by the components of CT enterography. Oral contrast. So we have a negative oral contrast and a positive oral contrast. The negative oral contrast, they started with water, but they found that water is absorbed rapidly by the small bowel, and this leads to non-uniform dilatation of the small bowel. Then they introduced milk, but the milk is not favorable by many patients. And then they started using other hyperosmolar agents, such as the laxatives, such as the methylcellulose, the mannitol, and the lactulose. In my institute, I'm using lactulose. Although we have requested the volumen, which is the contrast agent of choice, but it did not arrive yet. So the contrast agent of choice, and this is the one you should mention in your exams and your MCQs, is the volumen. We will talk about it in the next slide. Then there is a positive oral contrast. Some institutions, they use positive oral contrast, which is the non-ionic IV contrast agents, the Omnipaque and Isofew. But the ideal one is the negative oral contrast. The standard one is the volumen. This is what you should write in your exam paper. So what is volumen? It's a 0.1% weight per volume barium sulfate suspension with sorbitol. So sorbitol gives a sweet taste, and we're done with that. But why are we using barium sulfate? This adds osmolality to the oral contrast, and this will help to keep the water within the small bowel. Probably will attract water from outside as well. Hence, our aim, which is the distension of the small bowel uniformly from the ligament of Treitz down to the ileocecal bowel. What is the difference between this barium sulfate and the one used in routine fluoroscopy? The concentration, the one used in fluoroscopy, ranges between 20 to 40%. This one is 0.1%. So this might be an MCQ question. The volume is 450 milliliter. Remember that. The other component is the IV contrast. The total volume is 100 to 120 milliliter. Remember that as well. The rate is 3 to 5 milliliter per second, and it's better to use an injector. So the preparation of the patient, similar to any other CT study, he should be fasting for at least 4 hours, and the referring physician should explain to the patient that he will develop diarrhea after the study. This also should be explained to the patient by the CT technician, by the nurse, and by the radiologist. This is really an important part of the preparation of the study, because if you lose the trust of the patient and you didn't tell him that, he will not repeat the study with you and in your institution. So on the day of the exam, the total volume of the oral contrast is 1,350 milliliters. That is 3 bottles. So we start 1 hour prior to the study, and we give him 1 bottle, 450 milliliters at 60 minutes, then 450 milliliters at 40 minutes, and 450 milliliters at 20 minutes. So start 1 hour, then after 20 minutes, 40, 1 bottle, then after 20 minutes, 20, 1 bottle. So 20, 20, 20. And the CT technician, the nurse, as well as the radiologist should encourage the patient to drink the whole volume. So encouraging the patient, telling him everything about the study is really a crucial part of the study. Now, in your exams, it's better to write down this protocol, because I have read this in more than one reference and paper. But again, each institution has its different regimes and different protocols. Like one institution, they started 30 minutes before, and then every 10 minutes, they gave him 1 bottle. A different institution, they used the 1 hour protocol, but then at the 20 minute, they divided this dose into 2. So 225 milliliters at 20 and 225 milliliters at 10 minutes. But the standard one, the preferred one by me, is this one. And I find it more convenient because of the large volume of the contrast. I think this time is more tolerable by the patient. Okay. Then the phases of the IV contrast. This looks like the Mexican flag. So the one I use in my institution is the arterial phase and then the portovenous phase. Different institutions, they have different protocols. Some institutions, they do a pre-contrast, then they do an enteric phase, 40 to 45 seconds, and some institutions, they do a delayed phase. But the standard one, I prefer the arterial phase and the portovenous phase. I don't do the pre-contrast, the delayed, neither the enteric phase. So should we do an arterial versus late arterial enteric phase? I think that the arterial is more important because it will help me to detect bleeding lesions as well as hypervascular lesions like neuroendocrine tumors, as well as it will show the blood vessels. Now, what we mean by the enteric phase, it is the phase that it is found that this is the phase where the small bowel is adequately enhanced. But the portovenous phase also might show delayed enhancement of the bowel loops. So if you think about it, then I think the arterial and the portovenous are more convenient than doing an enteric phase, and it will lead to less radiation dose on the patient. So should we give buscopan and glucagon? No need in CT enterography, but it is needed in MR enterography because of the rapid acquisition of CT machines. In case of there are different CT scanners in one institute, it's better to use the bolus tracking. The field of view is from above the diaphragm to the symphysis pubis. The collimation is 0.625 millimeter. The interval is 0.625 millimeters. Then the reconstruction, axial and coronal, these are integral, and the coronal was really important to do. Then some institutions, they might do sagittals, maximum intensity projections, and volume rendering techniques. But in my institution, we don't do this routinely. Okay, so this is an example of a CT enterography case done in my institution. I will show you how beautifully the small bowel has been distended uniformly from the ligament of Trites down to the ileocecal valve. So I'll go back again and show you where is the ligament of Trites. So this is the second part of the duodenum. Okay, I hope you can appreciate this. And the third part is somewhere here. Then the ligament of Trites should be somewhere here. Then the proximal jejunal loops. This is the normal appearance of the proximal jejunal loops. They look really thicker mucosal folds, but then later on they will appear like this. These are the distal jejunal loops, and then the proximal ileal and the distal ileal loops. So again, you will notice that how beautifully these small bowel loops are distended. The distension of the colon is not important in these studies, but again, in this patient, it is colon. Even the colon is beautifully distended. Okay. The ileocecal valve should be somewhere here. Of course, this is not a diagnostic series. Okay. And the coronal, again, the same patient. Notice how beautifully the bowel loops are visualized. Okay. Of course, this patient has polycystic kidney disease, and it's due to renal failure and hemodialysis. So it's a uremic cystic disease. So how to read the CT enterography? Similar to any other abdominopelvic CT, follow the small bowel from the ligament of Trites down to the ileocecal valve. Report any lesion or abnormality, write it down, and then discuss it with your senior. With 3 to 5 cases, then you will be able to detect abnormalities and describe them adequately to your seniors. Then assess the mesoenteric space and the vasa recta, and then by the end, extraenteric findings. Now we'll talk about MR enterography. It's a newly introduced exam. It was developed due to the risk of repeating CT enterography studies and the risk of ionizing radiation on patients with Crohn disease with their young age. Again, we have the difference between MR enterography and MR enterocolitis is the administration of the nasoenteric tube. So indications, again, Crohn's disease. For follow-up, so this is really a crucial part. So CT enterography is done for newly detected cases of Crohn's disease or cases that we are not sure of the diagnosis. So patients with newly detected small bowel disease, let's say. If a patient was diagnosed with Crohn's disease, then MR enterography is the study of choice for follow-up to reduce the radiation dose. Okay. Another indication, if there's a contraindication to CT, such as pregnancy and contrast allergy, and in case of low-grade small bowel obstruction. Advantages: no ionizing radiation, better contrast resolution. There we say better spatial and temporal resolution. So this is an MCQ question. Better IV contrast options, gadolinium versus the iodinated contrast, so it does not cause a contrast-induced nephropathy. And we can do these studies in case of pregnancy, and the contrast is not needed because of the multiple phases in MR as compared to CT, which to a better degree can diagnose abnormalities. And it will provide additional information to perianal fistulous disease. Disadvantages: it's expensive, it's not widely available, less spatial resolution than CT, longer acquisition times, and variable exam quality related to the patient's cooperation and breath holding, and the need for extra medication that we need to give Boscovan and glucagon due to the long acquisition time as compared to CT. So the oral contrast, again, we have negative and positive. This is the whole table showing the oral contrast. But our oral contrast of choice is the volumen, as it keeps the water within the small bowel. The components of MR enterography, as we mentioned earlier, is similar to the CT enterography: the oral contrast, the volumen. The IV contrast is the gadolinium, 0.2 millimole per kilogram. The rate of injection is 3 milliliters per second. The preparation, similar to any other contrast-enhanced MR study, make sure that the renal function is adequate, no metals, no contraindication to the magnetic field, fasting for at least 4 hours, similar to the CT enterography. Make sure that there is no contraindication to Boscovan or glucagon, such as closed angle glaucoma. And we have to explain to the patient, the procedure to the patient, that he will develop diarrhea later on. So the dose of the volumen is the same as the CTE. I have chose the one given 1 hour before and every 20 minutes. Should we give rectal contrast? It's questionable. In my institute, we don't give that. The exam is done in prone position. In CT enterography, it is done in supine position. And Boscovan glucagon administration, it's variable from one institute to the other. Some institutes, they give the glucagon at the beginning of the study. Others, they give the glucagon just before the contrast enhanced sequences. So in my institute, we give it prior to the contrast enhanced sequences. Why? Because one of the sequences require to demonstrate the motility of the bowel, which is the fiesta or the syneloops. What are the sequences to be done? It's variable between 1.5 and 3 Tesla MRI. As a routine, just remember that we need coronal and axials, and we need post-contrast studies. Okay, don't remember these names. The most important sequence to remember, and it's really useful in such cases, is the syneloops. And the syneloop is known as fiesta in case of Siemens, and I think it's called vibe in GE, but I'm not pretty sure. So fiesta, vibe, or syneloops. This will demonstrate the motility of the small bowels. How it is done? It is done by taking cuts through the coronal section, through the sagittal section of the abdomen, doing coronal cuts, which stops at certain points, and then multiple images are obtained in each stub or cut, and this will demonstrate the motility of the small bowel. So the dose of glucagon, 1 milligram IV prior to contrast enhanced sequences, post-contrast sequences. This is an example of the fiesta or vibe sequence, and this demonstrates how the small bowel loops are moving. In my fellowship, by the end of my fellowship, this was the first sequence to look at. I used to look at this one first just to detect the abnormal segment. Okay, so you do demonstrate the breathing of the patient, and so you do see the breathing of the patient as well as the movement of the small bowel. Okay. So repeat again. Okay, hope it's clear. All right. Yes, it's clear here. And you do see the name Vista in the right lower corner. This is a coronal T2 without fat sat, coronal T2 with fat sat. It shows you beautifully the proximal bowel loops. I think this is the distal jejunum, and how beautifully they are distended with the oral contrast. Axial T2 without fat sat, axial T2 with fat sat. The abnormality is somewhere here. And this is the diffusion weighted axial sequence. Again, this is one of the advantages of the MR enterography. The abnormality is here. Coronal T1 fat sat post contrast, axial T1 fat sat post contrast. Sorry. So how to read an MR enterography? It's similar to reading a CT enterography. Start from the ligament of Trias down to the ileocecal valve. Assess the surrounding mesenteric space and the vasa recta. Look for extraenteric findings. Always correlate the post-contrast sequences to the T2 weighted images as well as the diffusion weighted images to assess for the disease activity. So, how does the inflammatory bowel disease appear in CTE and MRE? So, as I mentioned earlier, the main reason for developing enterography studies is to assess patients with Crohn disease. We want to detect the location of the lesions, and then we want to know the activity of the disease. So CT enterography is preferred as the first study for newly detected cases of Crohn's disease or suspected cases of Crohn's disease, and to exclude other causes. And as many patients with Crohn's disease are young, MR enterography was introduced to reduce the radiation dose on frequent follow-up. So I have discussed this earlier. So each institute has its own protocol. Some institute, they start with CT enterography as a baseline, and then the follow-up by MR enterography. Other institutes, they start by CT enterography, and then they alternate between CTE and MRE. Some institutes will follow the patient up with CT enterography, but with dose reduction methods. Okay. Now, the CT enterography and MR enterography are currently being used to evaluate the small bowel as well as the colon for other causes than Crohn's disease. As we were discussing earlier in MR enterography, some institutes, they do give rectal contrast just for full evaluation of both the small and large bowel. So Crohn's disease is classified as active inflammatory disease, and this requires medical attention or medical treatment. Then a penetrating disease. This is combined between medical and surgical, and an inactive long-standing disease. A variant of that is the fibrostenotic disease, and this requires surgical treatment if the patient was symptomatic. So how does the active inflammatory Crohn's disease appear in CTE? So number one sign is the mucosal hyperenhancement. So you do see the difference between the mucosa and the rest of the wall here. So this is called mucosal hyperenhancement. Of course, other findings include the circumferential mural extensive thickening, as well as the mesenteric fat stranding. So the mucosal hyperenhancement is the most sensitive. Number two, mural thickening. Similar to this case, there's a circumferential mural thickening. Number three is the comb sign. The comb sign is the prominent vasa recta. It looks like a comb. And when the comb sign is combined with the mesenteric fat stranding, this is the most specific. So the most sensitive is the mucosal hyperenhancement. The most specific is the combination between the comb sign and the mesenteric fat stranding. Something called mural stratification, when you see multiple layers in the wall of the small bowel. So you have a mucosal hyperenhancement, hypodense rim, and then isodense rim. This is called mural stratification. This is another sign of Crohn's and CTE. How does CTE in penetrating disease? It will demonstrate, you will be able to see a fistulous tract between two bowel loops, small bowel and large bowel, or two small bowel loops, or between two large bowel loops, or between a bowel loop and viscous, such as the urinary bladder, the uterus, the vagina. Okay, so here you can see a fistulous tract, and it has an enhancing wall. Here there is a fistulous tract between a small bowel loop and the cecum with a enhancing wall, and there is a mucosal hyperenhancement. This indicates an active disease with a fistulous tract. So Crohn's disease, inactive long-standing Crohn's disease, how it does appear in CTE? There will be a submucosal fat deposition, pseudosacculation. What is pseudosacculation? When you have two abnormal segments and there is a normal segment in between. So although it's a normal segment, but it will appear as a pseudosacculation because of the narrowing and fibrosis of the abnormal segments. The normal segment will appear as a sac-like structure, and we call it pseudosacculation. Lack of mucosal hyperenhancement. There will be a homogeneous enhancement of the wall. Lack of engorgement of vasoricta. There will be proliferation of the mesenteric fat, and thus the spacing between the bowel loops. And a variant is the fibrotic stricture, which might lead to small bowel obstruction. So this is the fat halo sign, or the fat deposition in the submucosa. Other causes of the fat halo sign: the ulcerative colitis, the radiation therapy, the chemotherapy, and the Cushing syndrome. How does active inflammatory disease appear in MRE? The same as CTE: mucosal hyperenhancement, circumferential mural thickening, mural stratification, the comb sign, and the mesenteric fat stranding. This is the patient I presented earlier, MRE in active inflammatory Crohn's disease. Additional findings include T2 hyperintensity. So you do notice that it's bright in T2, it's bright in T2 fat sat. In the diffusion weighted images, it will demonstrate bright signal and probably restricted diffusion. In both contrast studies, it will demonstrate the, as I mentioned earlier, the mucosal hyperenhancement and the prominent vasoricta. Now, one of the additional signs in MR enterography in the fiesta or the cine loops is the reduced motility of the involved segment. So this is the terminal ileum. You'll notice that the motility of this terminal ileum is relatively less than the rest of the normal small bowel. So hopefully you will be able to see this or appreciate it in this video. Again, this is the involved segment or the disease segment. Look at how it moves as compared to the rest of the small bowel. So it demonstrates reduced motility. No other similar segments are detected. So MRE in an active Crohn's disease, it's the opposite. It will be a dark signal in T2. So an active disease, it will be a bright signal in T2 and diffusion. In an inactive disease, it will be a dark signal, and you will probably demonstrate a fibrostenotic stricture. Extraintestinal manifestations of Crohn's disease in CT enterography and MR enterography, such as the perianal fistula and the sacroileitis. So in summary, the most important part is the preparation for the study and then giving him the proper dose with the proper timing of oral contrast. And then reading these studies is as simple as reading conventional CT or conventional MRI. Just follow the bowel from the start till the end. Thank you.
Thank you. Thank you to the chairs, the organizing committee, and the CCFA for the invitation. My morning was spent with multiple flight delays, so I'm thrilled to be here on time. But thinking back, last year I lost my wedding ring on the flight, and then I spilled my coffee on the guy next to me looking for my ring. So this was a much better day for me so far, so I'm hoping that trend continues. I have a few disclosures. What I'm going to do in the next 20 minutes, I'm going to start off kind of setting the stage. Just a brief 2 to 3 minutes about what's the standard of care in imaging and IBD. I'll talk briefly about the benefits, and then about CT and MRE, where are we now as far as them being interchangeable or equivalent. And then we'll segue into appropriate as well as inappropriate applications. We'll look at some data about how we're doing, and I'll close with some new developments which I think are quite exciting. Well, I think the first concept that we've all come to appreciate, symptoms aren't enough. There's multiple studies out there. Here's one from Jennifer Jones and colleagues. And this looked at correlations between a multitude of markers. In this study, it was high sensitivity CRP, IL-6, calprotectin, lactoferrin, and CDAI, or the Crohn's Disease Activity Index, a clinical scoring system. And what you can see if you follow this over to the last column, the correlation was poor. It was not significant between the endoscopic scoring system, the SES-CD, as well as the CDAI. And I think we see that in our practice every day. We see patients with symptoms that don't correlate with activity. We see patients who have responded to therapy that don't seem to improve. And I think it's all pushed us to say we need objective measures. Well, we're gastroenterologists. We do endoscopy. Why not just scope our patients? It's what we do. And I won't beleaguer this point. Dr. Wolf already talked about this a little bit. Dr. Sunil Samuel, when he was with us, looked at patients who had a normal ileoscopy but were felt to have active disease. And again, the point is, there's a significant proportion that you may miss if you don't image these patients, whether it's intramural disease, upper gut disease, or patients who have skipping. And then the last point, before I get to that, this is a nice example from the study. This was actually a patient with a normal ileoscopy and had normal biopsies. And what you can see if you look down there to the TI, the arrows point that out for you. You'll see enhancement, thickening. There's a suggestion of the comb sign, which is dilatation of the vasa recta to that segment of bowel. Not many here are radiologists, but I think most of us appreciate that's a floridly abnormal loop of bowel. This is a patient with active disease, and we would have missed that, even if we had biopsies of that segment. In addition to providing information about extent and severity of disease, imaging also allows us to pick up penetrating disease complications. This is similar to information we've gotten from emergency room settings where patients have been imaged. I think we've all been impressed by this. Your patients who come in who get cross-sectional imaging, this was a tertiary care center, almost 350 consecutive patients. 1 in 5, about 20% had penetrating disease, a new finding in more than 50%. And that's what imaging brings to the table. It not only allows you the full extent of disease, it also picks up penetrating disease. It'll also give you extraintestinal disease manifestations. Does it matter? None of this really matters at the end of the day if you're going to treat your patients the same way anyhow. If you're going to use the same drugs, maybe you say it doesn't matter if I'm missing a little more proximal disease. But multiple studies now suggest it does change how we take care of our patients. There's now data from MR enterography as well as capsule endoscopy, and it looks pretty similar. This was a prospective study in more than 250 patients, and the clinicians filled out their management plan prior to CT enterography and after. And what you can see up here, highlighted now in yellow, 50% of patients roughly with both suspected as well as established disease, CT did lead to management changes. It changed level of confidence for active inflammation, penetrating disease, as well as strictures. With that being said, before we move on, can we assume then that we can either do CT or MR? And the caveat is yes, most of the time. There's some subtle differences that I'll talk about, but I think we've gotten to the point in 2013, 2014 that good quality MR in our patients for active disease, CT and MR seem to have similar operating characteristics. This is a patient in one of our studies who had both CT and MRE. You can see down in the right-handed quadrant, there's evidence of Crohn's disease, there's tethered loops of bowel, there's evidence of thickening as well as enhancement. Well, how about the differences? And I bring this up because when we talk about appropriate or inappropriate use, I think it's the nuances of the techniques, the technologies that push us one way or another when deciding what's best for our patients. The advantages of CTE include less inter-observer variability, higher image quality, shorter acquisition times, 5 minutes, maybe as low as 2 to 3 minutes compared to up to 45 minutes for MR enterography. Cost, and I'll come back to that, but it can be anywhere between $1,000 to $1,500 in the United States. There's access issues. All of you have seen it's much easier in the middle of the night to get a CT, maybe not an enterography, but a CT even in the ER setting than it is to try and get an MR. And then there's a potential to do things like bone assessments, which I'll come back to. Advantages of MR enterography include the absence of ionizing radiation exposure. You can get multiple phases, and what I mean by that, if you see a loop of bowel that it's concerning for a stricture, you can actually in real time take a look at that loop and see with peristalsis if things open up. That's not something you would want or readily be able to do with CT. It may be superior for the detection of fibrosis. It is better for perirenal disease. And then pregnancy and renal insufficiency, I'll come back to both of those. There's some caveats. With pregnancy, we tried to avoid gadolinium in the first trimester. Renal insufficiency, there's some dose reduction, which I'll talk about in a little bit. So how do you go about figuring out the appropriate use? I took this from a friend and colleague in radiology, Dr. Fletcher, who's here. And whenever he talks to our residents and fellows, he talks about the name of the game is the right test for the right patient, picking out what's right for that individual. There's a number of resources you can use to try and guide this. This is a nice one by the American College of Radiology. If you Google or you go to acr.com, you'll find the site. This was expert opinion. There was a multidisciplinary panel. There were gastroenterologists as part of this. You can put in either the diagnosis or the modality, and what you'll come up with is expert opinion about various modalities in various clinical situations. This one here is an example of Crohn's disease. This is acute initial presentation. A 7, 8, or 9 score over here indicates it's most likely or it's highly appropriate. A 1, 2, or 3 means most likely inappropriate. And you can see in 2011, CT enterography was a 9, MR was an 8. I think nowadays you could probably score both as a 9 in this setting. It also gives you the relative risk or the relative amount of radiation exposure from both modalities. How do I put this together based on the literature? What are appropriate indications to consider imaging in our patients? I think the first subset is those with suspected Crohn's disease. It helps establish the disease. For me, at times, it helps guide where I'm going to get tissue, particularly in some difficult cases. It can guide antegrade versus retrograde double balloon endoscopy, help you define extent as well as severity of disease, exclude alternate etiologies, detect penetrating disease, stricturing disease, as well as extraintestinal disease manifestation. While those all hold true for established disease, in addition, you can use these for an objective measure for treatment response, and I'll come back to some of the bone things you can do with these as well. This is an example of lesion remodeling on CT enterography. This was a patient in one of our studies who in 2004 elected to go on monotherapy with anti-TNF therapy. You can see the initial image will be there to your left, and over time, by 2007, you can see almost complete normalization of the small bowel. I mentioned before about other new applications. This was presented at DDW this year, and we hope to go online with this in January. And that's the ability to take the CT, for example, and get additional information. You can get DEXA scores from CT now. You can also get bone strength. And bone strength is kind of the new kid on the block. It's what our endocrinologists like. Almost all phase 1 and phase 2 studies for resorptive agents or some of the osteoporotic medications use CT because of this. And essentially, what is bone strength? it's a measure of the amount of force that has to be applied to the bone to get a fracture. Now, CT has the ability to give you that in addition to other information, and why I think we like it. For CT, the cost of doing this is about $70. A DEXA scan's about $350. There's no extra radiation exposure. It's all post-processing of the images. So there's convenience, there's cost issues, and it may be a better marker overall of bone health, and it may change how many patients we're able to identify or screen for osteopenia or osteoporosis. So then, how do I image in practice? How do I choose which modality if they have an appropriate indication? To me, MR enterography is often employed, particularly in a younger patient, and to me that's 35 or younger. Serial examinations, renal disease, the caveat being with the gadolinium, clearance less than 60, it's half the dose, less than 30, we normally don't give that. Pregnancy, we mentioned about no gadolinium in the first trimester. And then stricture and perianal disease, those are times when I'll go to MR enterography. There are some examples on the left where I don't use either modality. There's small bowel follow-through, potentially in complex postoperative anatomy. Enterocolitis, either CT or MR can be done, particularly if they've had multiple negative studies and I'm still highly suspicious for a stricture. And then video capsule and ultrasound, I do think they have a role. It's not my topic, but just briefly, a capsule is very good for proximal disease. It's very good at looking at the mucosa. I do think eventually we'll see a role for ultrasound in the United States, even though we're not there quite yet. Well, how about misuse then? And unfortunately, I think this comes from either the wrong test, the wrong patient, or possibly both, the wrong test and the wrong patient. Some examples to me where we get this wrong would be multiple CTs in a young patient. I think we can do a better job. MR in the elderly, I think you could argue with me about that, and I put that up there mostly in the United States for cost, knowing that most of the risk or most of the sensitivities at a young age, the dose of CT, the radiation has gotten smaller and smaller, and there's about a $1,500 difference in cost. So I think you can make an argument for CT, particularly in an elderly patient without renal concerns. CT or MRE are not indicated for dysplasia detection. MR for inpatient with sepsis or SIRS, I point that out because occasionally we'll see that on the hospital services where a patient will go through the weekend waiting for MR enterography. If the patient's that sick that you're worried about penetrating disease, I think CT is a better modality, particularly if you can get it quickly. These are ill patients. You're asking them to drink 1.5 liters of volumen. Many of them are already nauseous. Then you put them inside a scanner. A CAT scan you can do very quickly compared to an MR where it may take 45 minutes to get the images. Patients with tremor or obese or diabetics where there may be a concern about giving glucagon, all reasons I think to think about CT enterography in that setting. And then again, MR at the bottom, we've talked about this for renal insufficiency in pregnant patients. How about wrong patient? And I'll come back to this. I think we all deal with a difficult setting, not just chronic abdominal pain, but chronic abdominal pain in the setting of IBD can be very difficult. And I think our colleagues in the ER need help or guidance on figuring out which patients damage and which patient not damage. So how are we doing if you look at what is the data out there? I think this was a nice study that sought to look at how we're doing, particularly in our younger patients. So this was a look at CT enterography in young patients. Initially, there was close to 7,000 CTs or 7,000 patients identified who had CT exams. When you break that down, a little more than 2,000 of those were less than age 35. If you follow that down a little bit further for how many had more than one CT, you can see there are about 192 patients. When we looked at those to say, well, young patients, serial CTs, how many would have been appropriate for MR? Didn't have a contraindication MR, particularly if the indication for the exam was to assess response to therapy, because I think all of us agree that's probably a better role for MR. You can see it comes out to being only 5% of the total number, but again, it's almost 100 patients. And so it's kind of glass half full, glass half empty. We're not doing that bad, but I do think there's room for improvement. Another way to look at this then would be, well, if you take the standpoint that there may be some level of radiation we want to avoid, there's some number that does portend a certain risk. This is a very muddy science, and I won't get into it. I'm happy to talk more after it. But the number a lot of times that people throw out is right around 100 millisieverts as a potential risk, and we try to avoid that as far as cumulative. What you can see from this cohort, a population-based study, is most of our patients don't. You see the numbers are higher as far as effective dose in millisieverts for Crohn's ulcerative colitis. Not surprising, we image Crohn's patients much more frequently. You can see at the very bottom the percentage from CT, most are from that. But I think it's this area here that has us a little bit worried. There is an upper quartile range of patients who do get more radiation, who do overcome or exceed, whether that's 75 or 100 millisieverts, and that's the group that I think we want to do a better job on because it tends to be the younger patients. Well, how about then looking at the emergency room, right? It's a lower hanging fruit. If we could just do a better job there, maybe we could reduce the radiation exposure. There's multiple studies that have looked at CT use in IBD patients in the emergency room setting. I like this one from Jim Lewis's group. It looked at several centers over a different period of time. And there's a lot of information that you can take out of this study. They looked at different intervals in time, and what they found is, yes, more patients are seen in the emergency room for IBD over time. We see imaging is more frequent. But at the bottom there, POA is perforation, obstruction, or abscess. POA and CD includes urgent non-Crohn's related findings. And it's similar to what I told you before. Almost a third, 25 to 30%, had these findings. So it's not enough to just sell the message, don't image my patient in the emergency room. We need better ways to risk stratify and tell them which patients should be imaged and which should not be imaged. No, there's several groups that have looked at this. Dr. Higgins, Dr. Abreu, there's various manuscripts out there. I kept a similar theme. This is from the same group that took it a step further and said, well, if we do need to image our patients, how can we make some type of model or risk stratification system to kind of guide who should be getting the images? There's various ways to go about this. They looked at various clinical as well as laboratory features of these patients. And what they found as far as the final model was a history of obstruction, history of intra-abdominal abscesses, current hematochezia, and a white blood cell count of greater than 12,000 were significant. And the way it works is you get a score of 1 for each of the variables, except for hematochezia that you subtract 1. And they were able, based on that, to develop who would be a low-risk population that probably doesn't need to be imaged. That's somebody with a score of -1. So in summary, I think we've evolved to the point where cross-sectional imaging has become a vital part of our practice. It's an objective measure of disease activity. It detects disease that may skip the terminal ileum. It detects intramural disease, penetrating complications, extraintestinal manifestations, and at the end of the day, it changes how we take care of our patients. As far as appropriate use, I think the applications continue to expand, but the key is always going to be matching the right patient with the right exam. I was asked to end briefly with where I think the future as far as this topic goes. I think in the next year or two you will see more publications about predictive models. You'll see increased guidelines to further assess or assist with when patients should be imaged in the acute setting, particularly in acute care emergency room. I do think that there may be a role for ultrasound in our algorithms. There's some question, at least for me, about how well it performs for penetrating disease, and that may be a particular concern in the emergency room setting where we're trying to limit radiation exposure. And I think in the next year or two, you'll see guidelines from various societies about imaging algorithms. I think we'll see more about what's appropriate or inappropriate, what timelines we should use for imaging, as well as standardization of the reports you get. And I think we all look forward to that. Thank you.